Hello everyone, I'm Dr. Ashok Jaiswal and today I'm going to discuss about a comprehensive management of non-alcoholic fatty liver diseases, in particularly focusing on primary care perspective. So what is non-alcoholic fatty liver disease? When more than 5% of liver cells are loaded with excessive deposition of fat, plus there is absence of history of significant alcohol consumption, which is defined as in male the consumption of alcohol less than 3 units per day and in female less than 2 units per day. Plus we exclude the presence of other chronic liver diseases like hepatitis B, hepatitis C or other autoimmune chronic liver disease. If you exclude, then this condition is called non-alcoholic fatty liver diseases, right? So more than 5% of liver cells having excessive fat deposition, no history of excessive alcohol consumption, no history of other chronic liver disease, you term that condition as NAFLD. And NAFLD is an umbrella term, and under this umbrella term you will see a range of liver condition. As you can see here in this slide, on your left hand side, under histopathological examination of liver biopsy, you can see here this white droplets, they are fat deposition, but you don't see any inflammatory changes, you don't see any liver cell injury. This is simple steatosis, we call it non-alcoholic fatty liver, simple steatosis, right? Now on the other side, on your right hand side, again under histopathological examination, you can see here this inflammatory changes. These are lobular inflammation, and here in this slide you can see injury to the liver cell. This particular liver cell, we call it ballooning of the hepatocyte, right? So lobular inflammation and liver injury leading to ballooning of liver cell, that condition we call it non-alcoholic steatohepatitis, right? So NAFLD, that is simple steatosis, can be detected by non-invasive imaging technologies using ultrasonography or transient elastography or MRI examination. However, to detect inflammation and ballooning, you require histopathological examination on liver biopsy. Right. So as the disease progresses from simple steatosis to NASH and further progression in the liver cell injury, it stimulates the fibrogenesis in the liver, and that leads to fibrosis in the liver cell, liver tissue. And it is this fibrosis which ultimately leads to adverse liver related clinical events like cirrhosis or decompensated liver disease, hepatocellular carcinoma, liver transplantation, and mortality. Right? So, once again, I repeat, it is the fibrosis which ultimately leads to adverse liver related clinical endpoints. So, how big is this problem? Globally, every 1 out of 4 in general population, they do suffer from non-alcoholic fatty liver diseases. But if we go by the recently published meta-analysis and systemic review analysis conducted from India, it showed the prevalence to the tune of almost 38 to 40% of the general population. What is more important, 35% of children in India, they are also suffering from non-alcoholic fatty liver diseases. Right. So what is driving this huge epidemiological burden of NAFLD? It is the underlying insulin resistance, which is responsible, which is a root cause for the multi-system inflammatory metabolic derangement. And NAFLD is just a liver expression of that multi-system systemic inflammatory metabolic disorder. So it is the insulin resistance, and we all know that we Indian, we suffer from insulin resistance at least a decade advanced compared to our Caucasian counterpart. So insulin resistance is a major problem being Indian phenotype, and it is the insulin resistance which leads to metabolic disorder, which lead to systemic inflammatory milieu, leading to multi-system disorder including non-alcoholic fatty liver diseases. So, as I just made a mention that around 38% of Indian population, general population in India, they suffer from NAFLD. But if you take a specific cohort of patient having various metabolic disorder like obesity, then the prevalence is to the tune of 90%. Type 2 diabetes, hypertension to the tune of 70%, patient having atherogenic dyslipidemia like high TG and low HDL, around 80% of those people will be suffering from non-alcoholic fatty liver diseases. Now, more the number of metabolic features, more is the probability of having non-alcoholic fatty liver diseases. Now, this is a very recently published paper in March 2023 from Journal of Hepatology. What this study did, they studied a cohort of type 2 diabetes mellitus, right? And what they showed, 65% of those type 2 diabetic patients, they were having non-alcoholic fatty liver diseases. But what is more important, 15% of type 2 diabetes patients, they had advanced stage of fibrosis, and this is the advanced stage of fibrosis which is responsible for the clinical events like cirrhosis, HCC, liver failure or transplantation. And in this study, around 6% of those type 2 diabetic patients, they had cirrhosis. So this is what a very tight association between insulin resistance and type 2 diabetes with NAFLD. And it is not only the prevalence of NAFLD high in patient having type 2 diabetes mellitus, but it is also the rate at which disease progresses. In type 2 diabetic patient, presence of NAFLD become more aggressive. As you can see here in this slide published in Hepatology Data in 2018, this paper compared non-diabetic NAFLD patient with type 2 diabetic patient having NAFLD. And as you can see here, in non-diabetic NAFLD patient, around 10 to 20% they progress to NASH. But if the patient is having type 2 diabetes, then almost 40% of NAFLD progresses to the NASH. So it is the severity of the disease that NAFLD become more severe, more aggressive if the patient is also having type 2 diabetes in terms of progression to NASH, in terms of progression to cirrhosis, HCC and mortality. Now, it is not only the liver related event which are very much increased in patient having non-alcoholic fatty liver diseases, but now we have enough data indicating that patient with non-alcoholic fatty liver diseases, they have multifold higher risk of cardiovascular event compared to people having no fatty liver diseases. This is once again because the underlying root cause pathophysiology is similar in cardiovascular disease and the non-alcoholic fatty liver disease, and that is the common pathophysiology of insulin resistance and associated metabolic disorders. So the question is, whom should we screen NAFLD in our clinical practice? Because majority of patient with non-alcoholic fatty liver disease, they are asymptomatic. They become symptomatic only when patient advances to the tune of development of cirrhosis or decompensated liver failure. So this is a critical question, whom should I screen, right? Now if you refer any global guideline or maybe Indian guideline like the global guideline like American Association for Study of the Liver Disease, or European guideline, European Association for Study of the Liver, or American Diabetes Association guideline, they all recommends that we must screen all our patients having obesity, overweight, or having insulin resistance, pre-diabetes or type 2 diabetes or dyslipidemia, or any patient having metabolic disorder. All those patients in our clinical practice, they should undergo the screening for the presence of non-alcoholic fatty liver diseases. Now the question is, what should we screen? Should we screen the amount of fat deposition liver, or should we screen for the presence of inflammation or the liver injury, or we should screen for the presence of fibrosis? The data and the guidelines suggest that we must screen the grading of fibrosis in our routine clinical practice in all those high risk people having metabolic disorder. Why? Because the clinical data establishes a strong predictability of fibrosis with adverse future risk of liver related event. The data suggests that more the fibrosis, more is the risk of liver related endpoints. That's why it is imperative for all of us to grade fibrosis in patient having metabolic disorder. So how do we stage or grade fibrosis in high risk NAFLD population? We grade fibrosis from F0 to F4. F0 means no fibrosis, F1 minimal, F2 clinically significant fibrosis, F3 means advanced fibrosis, and F4 it's cirrhosis. Now, if you look at this line chart, which is very interesting, if NAFLD patient is having F0 or F1 grade fibrosis on x-axis, look at the mortality rate on y-axis. It is not elevated compared to general population. So if NAFLD person having F1 or F0 fibrosis, the person is not having elevated risk of future liver related event or mortality. But as you go beyond F1 fibrosis, if you move from F1 to F2 fibrosis to F3 and F4, there is exponential rise in liver related event and mortality, right? That's why in our clinical practice, it is very important for us to rule out the presence of F2, that is clinically significant fibrosis, F3, that is advanced fibrosis, and F4, that is cirrhosis. So how should we grade? Should we go with liver transaminase value, liver enzyme value to rule out NASH? The data suggests no. Liver transaminase, they are not sensitive biomarker. As you can see here in this slide, around 80% of NAFLD patient will have normal liver transaminase value, and around 50% of NASH patient will have normal transaminase value. So you cannot rely on liver transaminase to rule out non-alcoholic steatohepatitis. Then the question comes, how should we grade fibrosis? Should we require biopsy for each and every patient? Answer is no. Biopsy cannot be done in our routine clinical practice to each and every NAFLD suspected patient. Biopsy has its own limitation. So we have non-invasive, biochemical and the clinical marker based scoring system. Like one which is presented here in this slide, it is called FIB4 scoring. Now, what do we require to do FIB4 scoring? We require 4 parameters: age, AST, ALT, and platelet counts. We routinely do, complete blood count and a liver function test in almost each and every patient who visit our clinic. So you will have very easily access to these 4 parameters. What you require, you just Google FIB4 calculator in your smartphone. The calculator will open up, feed this 4 value, enter, and you will get your FIB4 scoring value. This scoring is so simple and easy, it hardly takes 10 seconds in your smartphone. Now, how do we interpret the FIB4 reading? Now, if the FIB4 score is less than 1.3, that means you rule out the presence of significant or advanced fibrosis. Look at the negative predictive value. It has excellent negative predictive value of 95%. So if your patient is having FIB4 less than 1.3, then that patient has no high risk for the future liver related event or liver related mortality, and I will categorize those people into this low risk for liver event category. That means I am ruling out the presence of F3, F4. The patient is having low risk. Now, if the FIB4 score is more than 2.6, then it predicts the advanced fibrosis. That means the patient is having advanced fibrosis. That patient will fall into this category of high risk probability for the liver event and the mortality. All such patients should be referred to the specialist, liver specialist, for further evaluation and management, because there the management line is very much different, keeping the objective of preventing cirrhosis and decompensated liver disease in mind. Now, what if the patient's FIB4 is between 1.3 to 2.6? We call that category as indeterminate group, and this is where I will recommend my patient to undergo for further subsequent evaluation through non-invasive imaging technology. The one which is most commonly recommended is transient elastography, like fibroscan. So I will ask my patient to undergo fibroscan evaluation, and based on fibroscan result, I will once again categorize that indeterminate category patient to either low risk or either into the high risk, right? Remember, 85% of your NAFLD patient will fall into this category, having FIB4 less than 1.3. And this 85% of NAFLD, low risk NAFLD patient, they do not require referral to the liver specialist. They should be managed at the level of primary care physician only. So that management we will discuss in the later on slides. So this is what I was mentioning. Google the FIB4 calculator. You will get the calculator open. Feed the 4 parameter age, AST, ALT and platelet value, and you get the scoring of FIB4 done. Now, how strong evidences we do have on FIB4 establishing its association with the adverse clinical outcome? This is a wonderful study conducted by Professor Dr. Arun Sanyal, and what he did, he studied more than 2,500 high-risk patient population of NAFLD, and he did FIB4 scoring of all those 2,500 patient population, and then he classified them into 3 category: class A if FIB4 less than 1.3, class C if more than 2.6, class B means if FIB4 is between 1.3 to 2.6. Now look at the rate of liver events in these 3 class of the patient. In class A, the liver related events were very less, only 0.21. But look at the class C, that is high risk, 9.33, almost 40-fold increase in the risk of liver related event if your FIB4 increases from 1.3 to more than 2.6. So this is what the clinical significance of FIB4 scoring. And if you look at the major adverse cardiovascular adverse event, that also jumps from 0.83 event rate in FIB4 less than 1.3 to the event rate of more than 2.5. So it also indicates that NAFLD patient, they not only have higher risk of liver related event, but they also have multifold increase in the risk of cardiovascular events. So how do we manage a patient with non-alcoholic fatty liver diseases? This is a beautiful algorithm proposed by and provided or recommended by American Association for the Clinical Endocrinologists, AACE 2022 guideline. What AACE 2022 guideline says that all high-risk metabolic disorder patient having prediabetes or obesity or having multiple cardiometabolic risk factor or the patient having elevated liver enzyme, all such patients should be suspected for the presence of NAFLD. And in those patients, I have two objectives. Number one, I need to prevent the future cardiovascular events. So what should I do? I should manage the patient with lifestyle modification, weight reduction, exercise, and the dietary modification is key. Manage hyperglycemia, insulin resistance, hypertension, atherogenic dyslipidemia, and so on and so forth. And the second objective in those people is preventing the future liver related adverse event and mortality. So what AAC guideline tells me in those patients, it says that you risk categorize the patient based on the fibrosis grading. That means do the FIB-4 scoring and categorize your high risk population into one of these three category of liver event: low risk liver event, high risk liver event, or indeterminate risk. Okay, so what guideline says that after doing FIB-4, if the patient falls into this category of low risk liver related event, treat those patients at primary care level only, do not require the referral. Weight loss, dietary management, exercise is the key. Manage the cardiovascular risk factor. If the patient falls into the high risk category, refer to the specialist. If the patient falls into indeterminate risk, ask the patient to go for further evaluation by non-invasive imaging technology like transient elastography. Now, what is transient elastography? The most commonly used technology in today's clinical practice is vibration controlled transient elastography, VCTE. This is the technology used by one machine which is commonly available in today's scenario, that is FibroScan. Now, this transient elastography, it is a very simple bedside test. It takes hardly 5 minutes, and when you do transient elastography, VCTE, you get two type of value. As you can see here in this slide, the one value, one which is in orange color, it gives you the measurement of liver stiffness measure, LSM, in kilopascal, right? And it indicates how much is the fibrosis. Higher the LSM, more is the fibrosis, right? And the second value which you get on fibroscan is in blue color, that you can see here, it is 355. This value is called CAP, controlled attenuation parameter, and it tells you how much fat is deposited. Higher the CAP value, more is the fat deposition. So what is more important? More important is LSM, liver stiffness measure in kilopascal. Now, how do we interpret? Okay, if LSM value of your patient less than 8 kilopascal, then the patient has a low risk of future liver event or mortality, right? Manage at primary care level, cardiovascular risk management. If the patient is having LSM value of more than 12, the patient is in trouble. Patient might have advanced fibrosis or cirrhosis. Refer the patient to the liver specialist. And if the patient is having LSM value 8 to 12 kilopascal, then that patient is having clinically significant fibrosis, right? So that is how we interpret the results on fibroscan or transient elastography. So how should we manage? As I just made a mention, the lifestyle therapy, weight loss is the key. it is the most effective treatment strategy currently. Any weight loss in patient having NAFLD is welcome. As you can see here in this slide, more than 3% weight reduction, you will reduce steatosis. More than 5% weight reduction, you reduce ballooning and inflammation. More than 7% weight reduction, you resolve NASH. And if you can achieve 10% or more than 10% body weight loss, then you are even achieving fibrosis regression. So it is very, very important. However, in clinical practice, we have our own challenges. Number one, achieving this target of 10% weight loss itself is a difficult task. And number two, even if you achieve this task, then sustaining the 10% weight loss, it becomes even further challenging. So many a time we require pharmacotherapy in patient having non-alcoholic fatty liver diseases. So do we have any pharmacotherapy? Globally, today there is no approved drug therapy for NAFLD or NASH. However, we do use certain medicines in patient having non-alcoholic fatty liver diseases, like we might be using metformin or vitamin E or glitazones like pioglitazone or ursodeoxycholic acid or obeticholic acid. However, remember, all these drugs are being used in NAFLD off-labeling, right? They do not have enough evidences showing the histopathological benefits in patient having NAFLD or NASH. Now, if I refer a very recently published American Association for Study of the Liver Disease 2023 guidance published in Hepatology, what it says, vitamin E can be considered in the treatment of non-diabetic NASH patient. It also says there are data available on GLP-1 agonists like semaglutide or glitazone, pioglitazone, vitamin E, but they do not demonstrate an antifibrotic benefits on histopathological examination. And at the same time, ASLD also says that metformin, UDCA, DPP4 inhibitors, statins, and silymarin, they are well studied in NASH, and they should not be used as a treatment for NASH, as they do not offer meaningful histological benefit. So what is the role of saroglitazar in NAFLD management? As we all know, there is only one drug approved in India by DCGI, that is saroglitazar, for the treatment of NAFLD with comorbidities and patient with non-cirrhotic NASH. Now, saroglitazar has many evidences. As you can see here in this slide, saroglitazar has 8 evidence series of clinical trial. When I say evidences series of clinical trial, evidence 1, 2, 3, 4 to 8, they all are conducted in patient having NAFLD and NASH. The studies are getting conducted in USA, India, and Mexico. There are 2 EPIC series of trial of saroglitazar for the indication of primary biliary cholangitis, 10 PRESS series of clinical trial for the indication of diabetic dyslipidemia and hypertriglyceridemia. There are many post-marketing, observational, or investigator-initiated studies, including a registry. All these data are available in public domain. Now, what is the mechanism of action of saroglitazar? We all know it has a dual PPAR alpha and gamma action. Predominantly, it has PPAR alpha action. PPAR alpha, they are the nuclear, transcription factor, and they are predominantly present in liver tissue. When saroglitazar activate the PPAR alpha receptor, it increase the fatty acid uptake, increase the fatty acid oxidation, and hence it reduces the triglyceride rich lipoprotein particles TG and VLDL, and it also reduces inflammatory changes. It has moderate PPAR gamma action. As we all know, PPAR gamma are predominantly present in adipose tissue, and that is where it improves the insulin sensitivity, it improves the glucose uptake, and it increases adiponectin release, and it reduces inflammatory changes as well. What is the postulated mechanism of action of saroglitazar in NAFLD and NASH? As we all know, there are 3 heat therapy pathophysiology of NAFLD and NASH. First heat is increase in the lipid deposition in liver, that is excessive triglyceride deposition in liver tissue. And we all know Saroglitazar, it significantly reduces triglyceride and hence it reduces steatosis. Second, HIT therapy, what we know that there is a development of inflammation in the liver through activation of Kupffer cell, and the activation of Kupffer cell, it increases the release of inflammatory cytokines, and we have data from in vitro studies and preclinical studies. They showed that Saroglitazar, it significantly reduces the activation of Kupffer cell, it significantly reduces the release of inflammatory cytokines. The third hit theory is the development of fibrogenesis in liver cell through activation of hepatic stellate cell. This activation of hepatic stellate cell, it leads to fibrogenesis, leading to fibrosis in the liver. And we have data indicating that Saroglitazar, it decreases the activation of hepatic stellate cell, and hence it may reduces the fibrogenesis in liver of patient having non-alcoholic fatty liver diseases. So this study of Saroglitazar, it has been conducted at endocrinology department of PGI Chandigarh, and the results are published in Scientific Reports 2019. And this is interesting study because this study evaluated the efficacy of Saroglitazar on insulin sensitivity on euglycemic hyperinsulinemic clamp study. As we all know, euglycemic hyperinsulinemic clamp is considered as gold standard to measure the insulin sensitivity. Now, in this study, treatment-naive type 2 diabetic patients, they were enrolled and then they got randomized to either Saroglitazar 4 milligram treatment arm or placebo arm. At baseline, they underwent euglycemic clamp. Then they were provided treatment either with Saro or placebo for 4 months. And then again after 4 months, euglycemic clamp was repeated to see the change in insulin sensitivity index and glucose disposal rate. As you can see here, there was no any significant change observed in placebo arm on insulin sensitivity index, but there was significant improvement in insulin sensitivity index was observed after 4 months treatment with Saroglitazar compared to baseline. Also, you can see here the effect on glucose disposal rate. The glucose disposal rate of 1.6 at baseline got significantly improved to 3.2 after 4 months treatment with Saroglitazar arm. Okay, this is a systemic integrated review analysis which is published in cardiovascular diabetology in the year 2019, and this is a review analysis of 18 post-marketing observational studies of Saroglitazar involving more than 5,800 patients, and the result of this integrated analysis showed triglyceride reduction ranging from 45 to 62%, non-HDL on average of 30% reduction, HbA1c ranging from 0.7 to 1.6% reduction, a significant reduction in liver transaminase value, and there is a significant reduction in highly atherogenic lipid particle. We call it small dense LDL particle. So you can always expect SDLD reduction to the tune of almost 20%. Study. This is a phase 2 study conducted in India that is named as Evidence 1. Here, the biopsy proven NASH patients, they were given Saroglitazar 4 milligram, and as you can see here, there is a significant reduction in the primary endpoint of alanine aminotransferase from baseline 95 to week 12 44. There is almost 50% reduction in liver transaminase after 12 weeks treatment with Saroglitazar. And then we have a phase 3 placebo controlled randomized double blind biopsy driven clinical study in NASH patient, and this study was biopsy driven. 102 patients having biopsy proven NASH were enrolled in this study. All those patients were randomly divided into Saroglitazar 4 milligram or placebo arm. The treatment was given for 52 weeks and second biopsy was taken after 52 weeks of treatment. So these are the key inclusion and exclusion criteria of this phase 3 clinical trial. As you can see here, the enrolled patients were adult of 18 to 65 years of age. They were having histological confirmation of NASH without cirrhosis. That means only fibrosis stage 1, 2 and 3 they were enrolled. The patients having fibrosis F4 grade were excluded. The patient should have baseline NAFLD activity score on histopathology. The score should be of 4 or more than 4. Now, what was the primary endpoint in this phase 3 clinical trial? Primary endpoint was decrease in NAFLD activity score of at least 2 and more than 2 without worsening of fibrosis. Means the percentage of the patient achieving this primary endpoint, and as you can see here in this slide, 52.3% of the patient in Saroglitazar arm, they achieved this primary endpoint of NASH reduction by at least 2 or more than 2 without worsening of fibrosis, compared to 23.5% patient achieved it in placebo arm. And this difference between the two arms was found to be statistically significant. And based on this primary endpoint results, Saroglitazar got DCGI approval for the treatment of non-cirrhotic NASH in India. In the same phase 3 study, we have seen a significant improvement in steatosis by 41%, ballooning reduced by 35%, lobular inflammation improved by 12%, but not statistically significant. As you can see here, there was significant improvement in we have observed in various lipid parameters as well as liver enzymes also. This is a phase 2A clinical trial conducted in USA and the results are published in Hepatology 2021. Total 106 NAFLD patients with baseline ALT more than 50 unit per liter. They were enrolled and they were randomized to either Saroglitazar 1 milligram or 2 milligram or 4 milligram or placebo for 16 weeks. And the primary endpoint was percentage change in ALT values from baseline at the end of 16 weeks follow-up. All patients also underwent evaluation of liver fat content measured by MRI-PDFF technology. Now, as you can see here, the percentage change in ALT value was 45% reduction in Saroglitazar 4 milligram arm. Then AST value was reduced by 25%. Alkaline phosphatase reduced by 35%. GGT was significantly reduced by 45%. So there was significant improvement in the liver enzyme values after 16 weeks treatment of Saroglitazar 4. And as you can see here, the percentage of the patient who achieved 50% reduction in ALT value was much higher in Saroglitazar 4 milligram compared to Saroglitazar 2 or Saroglitazar 1 or placebo arm. This is the latest recently published Indian guideline from Indian National Association for Study of the Liver. That is, association is called INASL. INASL has very recently released its own NAFLD clinical practice management guideline. And what INASL says that INASL again reiterate the significance of weight loss, dietary modification, and exercise. They are the key in the treatment of patient having NAFLD and NASH. INASL also recommends pharmacotherapy. INASL recommends predominantly 3 pharmacotherapy. One is vitamin E, second Pioglitazone and Saroglitazar. Vitamin E 800 international unit daily. It is recommended in non-diabetic NASH patient, but we have to be very careful for the risk of hemorrhagic stroke and increased risk of prostate carcinoma, and hence we have to be little careful while prescribing vitamin E in elderly people who are already at higher risk of developing prostate cancer. Pioglitazone, the recommended dose in NAFLD and NASH is 30 mg every day. It may be useful in case the patient is having type 2 diabetes because it is anti-diabetic and insulin sensitizer as well. However, we need to be careful and we need to monitor for the weight gain, edema, and the risk of future cardiovascular event. The third drug is Saroglitazar, which is the only approved drug by DCGI for the treatment of NAFLD and NASH. The recommended dose is 4 mg every day for the minimum duration of 1 year. It decreases ALT, improves insulin resistance, it improves atherogenic dyslipidemia, it reduces steatosis, it reduces NASH value on histopathological examination. So to summarize, we have a rising trend in the prevalence of metabolic disorders, and at the same time we have increasing burden of NAFLD and NASH as well, because both are interconnected, they go hand in hand, and the root cause is common, that is insulin resistance. The NAFLD in current clinical scenario has become a leading cause of hepatocellular carcinoma as well as a causative factor of liver transplantation. Now, whom should we screen? We should screen all our patients having metabolic disorders, including obesity, diabetes, dyslipidemia, hypertension. And what should we screen? We should screen for the fibrosis staging, right? So, do we require biopsy to grade fibrosis? Answer is no. We can use biochemical parameter based scoring system, or we can go for non-invasive imaging technology. For biochemical based scoring system, we have FIB4 scoring, which is very simple, requiring only 4 parameters: age, AST, ALT, and platelet count. Go to your smartphone, Google it, and do the calculation. And then you have non-invasive imaging technology like transient elastography. For example, fibroscan is also nowadays available in our clinical practice to grade fibrosis. Weight loss, dietary modification, exercise is the key in the management. Vitamin E, UDCA, pioglitazone, they all are off-label use. UDCA should not be used for the treatment of NAFLD and NASH. Vitamin E can be considered in non-diabetic NASH. Pioglitazone can be considered at the dose of 30 mg per day. Be watchful for weight gain, edema. Saroglitazar is the only drug approved in India by DCGI for non-cirrhotic NASH and patient having NAFLD with comorbidities like obesity and diabetes. It improves insulin sensitivity, it improves atherogenic dyslipidemia. For liver specificity, it reduces steatosis, it improves LSM on VCT, and it reduces NAFLD activity score on histopathological examination. Thank you very much for your patient hearing.